Hello, everybody. Welcome to my YouTube channel, Academics at the Rate Critical Care. And today's topic is non-invasive ventilation, trick of the trade. I think we all are aware of this picture. This is during the time of polio pandemic and the picture of the iron lung. When with this ventilatory support, we were able to save a lot of life. And the journey of non-invasive ventilation had started from that day. And what we have done, we have moved from negative pressure ventilation towards positive pressure ventilation. In the year 1940, Motley and colleagues at Bellevue Hospital had used IPPV via an anesthetic mask in acute respiratory illness. And after that, over next 2 decades, the non-invasive ventilation has developed tremendously along with the invasive ventilation. Its usage becomes so widespread by the year 1970 that more than 10% of all hospitalized patients was on NIV. And because of that, National Institute of Health and American Thoracic Society decided to organize a conference to streamline its use, which was called Sugarloaf Conference. And in the 90s, the evidence in its support progressively increasing. We have used it for chronic obstructive pulmonary disease, post-operative patient, restrictive thoracic disease, congestive heart failure, restrictive parenchymal lung disease, and any other different causes. The evidence gradually becomes so robust that in the year 2020, ISCCM has published Indian guideline for usage of non-invasive ventilation. So whenever we are putting a patient on NIV, we have to keep certain things in mind to make it successful so that we can manage the patient with NIV and that patient does not go to invasive ventilatory support. So there are some tricks or some important aspects that we need to keep in our mind. Most important, and the first one is to know your machine. Whenever we are using ventilation, it can be volume supported or volume targeted and pressure targeted. In volume targeted modes, more assured tidal volume will be there, but it fails to compensate the airflow for patients' varying need and because of the circuit leak. In sick patients, sometimes have a very high minute ventilatory rate along with very high flow requirement. Sometimes volume targeted modes fail to support that. So we are not used it routinely in our practice. And mostly what we prefer is a pressure targeted ventilation when it can manage the leak better, which is inevitable in a non-invasive ventilation, and it improves patient comfort and synchrony with patient control inspiratory flow. Here the patient can decide how much flow he or she needs. And when we combine the advantage of both these two modes, we are now using volume targeted pressure ventilations. But if you look at the data, both modes are equally efficacious in decrement of the CO2 level with no difference in intubation rate and hospital mortality. What are the other things we need to set? We know we have to set IPAP and EPAP. How are we going to set it? EPAP is expiratory positive airway pressure. So we start with an EPAP. We start with a pressure EPAP of around 4 to 6 and now gradually increase it till each and every patient's respiratory effort converted into a breath. That will be our target. Now, once we set the EPAP, then we adjust IPAP. If the EPAP is 6, probably we start with an IPAP of 12, so that the pressure support is around 6. What is our target while setting an IPAP? We'll start with the 4 to 6 of IPAP, then gradually increase till patient is able to draw around 6 to 8 ml per kg of tidal volume. Once it is done, that should be the minimum EPAP and IPAP that patient is need. Now, depending on the other parameters, you may need to adjust it. For triggering, we have two options, flow trigger and pressure trigger. And studies have shown that flow trigger is better than pressure trigger because of shorter trigger delay and better synchrony. It is more applicable for COPD patients as it causes less autopsy. But the minute ventilation, respiratory pattern, dynamic lung compliance and resistance, and the changes in the end expiratory lung volume, all other respiratory parameters are more or less same with both triggering systems. Now, regarding the cycling, If the patient is on pressure support mode, we mostly use flow cycle. But in NIV, if there is a large leak, this causes interference with the flow cycling. And in that situation, it is better to shift to pressure control mode with a time cycle breath. There is a better synchrony with that. There are some hidden settings that a lot of time we do not change or do not touch or monitor, but those are very important. One is backup rate. In ST mode, there is a backup rate inbuilt into the machine. Whenever you on it, it usually goes to 20 per minute. But in a apparently stable patient, 20 respiratory rate may be too high. So we have to keep it in mind. And most of the patients, when you are using NIV, patient is conscious and may be able to trigger the ventilator, trigger the NIV. In that situation, backup route is not that important. So to prevent hyperventilation, it is better to decrease the backup rate to 8 to 10 per minute. Next important is TI or inspiratory time. As I mentioned, mostly in the NIV, the inbuilt backup rate is 20 with a TI of 1 second. So that every respiratory cycle is 3 seconds, inspiratory time 1 second, and expiratory time 2 seconds. But once the patient is breathing at a rate of 30, then because the TI is 1 second and the respiratory cycle is now 2 seconds, the expiratory time becomes 1 second, which is insufficient for most of our patients. So it is very important to adjust your TI or inspiratory time depending on the patient's respiratory rate. Probably we have to decrease the TI, and in certain patients like COPD, probably we have to decrease it to give the more expiratory time in them. Third important aspect is the rise time. It is the time required to reach the peak pressure to deliver the gas. Now, if the rise time is very small, the patient may feel a rapid gush of air into his face or in the respiratory tract and may not tolerate, and probably it can decrease the compliance. And if the rise time is very high, patient may have an air hunger because the flow is low and patient is not able to, that may not be able to cope up with the patient's requirement. So again, we have to be at the bedside and have to adjust the rise time depending on the patient's requirement. We can deliver non-invasive ventilation by two modalities. One is a small portable ventilator, which is conventionally called BiPAP, and another is the ICU ventilator. Most of the ICU ventilators can provide non-invasive ventilatory support because of the inbuilt software nowadays. What are the advantage and disadvantage? In portable or BiPAP or bilevel ventilation, the circuit usually single limb with a passive exhalation valve. And the exhalation valve is near the mask. We have to remember that because of that, we need to use a vented mask in a bilevel ventilation because there is no other expiratory port. This is a very important point. And there are some other advantages like it's a portable, easy to use, can be used for the home ventilator also. But the disadvantage is it cannot deliver a predictable FiO2 because we are giving oxygen along with during ventilation, and there is a gas mix, and depending on the patient's respiratory effort and the minute ventilation, the FiO2 may vary. On the other hand, whenever you are using ISO ventilation, it usually have a dual limb with an active exhalation at the end of the expiratory limb, like other conventional ventilatory system. And advantage is that it can deliver a predictable FiO2. But the disadvantage is that these are big modes, so you have to be in ICU. And if it does not have a dedicated NIV mode in it, it may not be able to compensate for the leak because this ICU ventilator is not habituated to have leak. And there are other newer modes are coming, like average volume assured pressure support, intelligent volume assured pressure support, proportional assist ventilation, adaptive servo, adaptive support ventilation. The main target is that to deliver a predictable tidal volume with adjustment of the pressure support depending on the patient's requirement. So now in the first two modes usually monitor the tidal volume and they adjust the pressure support accordingly. In the last two usually monitor the PAVN, monitor the compliance and resistance, and accordingly they changes the support in the machine because as per the pre-filled software in them. The last one, neurally adjusted ventilatory assist, is much more interesting. What it has done, it usually senses the respiratory effort at the neural level. And as a result, even if because of neuromuscular weakness, because of autopip, we are not able to generate adequate flow, as it's sensing the neural requirement, the neural activity, electrical activity, it can deliver the breath. So the time delay is less and the synchrony is much better. And the chance of wasted ventilation is very less with that. Though we do not have a large data of NAVA in non-invasive ventilation. Next important aspect is we need to choose our patients correctly to have a successful NIV travel. This is an ICCM guideline and for use of non-invasive ventilation, acute respiratory failure, and eventually they have put all causes of respiratory failure into that. Along with that, there are some contraindications, standard contraindications of NIV that we all are aware, like when the patient is unable to protect the airway, patient is hemodynamically unstable, there is inability to fix the interface because of some facial trauma or because of some other reason, inability to, patient has a severe GI symptom, massive hemoptysis, copious secretion, or patient is in a post-cardiac arrest scenario. But whenever we are using NIV in acute respiratory failure, there are some indications where you should use non-invasive ventilation to begin with. These are acute exacerbation of COPD with acute or acute on chronic respiratory acidosis, pH 7.25 to 7.35, that is moderate acidosis. Patient with acute exacerbation of COPD with a pH less than 7.25 before initiation to invasive mechanical ventilation. That means we put this patient on NIV and proceed for invasive ventilation. Acute cardiogenic pulmonary edema without hemodynamic instability. And in that situation, if the patient has associated hypercapnia, BiPAP is better than CPAP. For reducing dyspnea in palliative care setting, for postoperative acute respiratory failure patients, specifically in cardiothoracic surgeries. Here we need to remember that most of the postoperative acute respiratory failure is because of basal atelectasis and collapse. And so the positive pressure ventilation can help significantly. But if there is a pneumonia in the postoperative failure and that causes acute respiratory failure, we have to use NIV very judiciously. And there may be a clinical failure with NIV. We should use prophylactically to wean high-risk patients from invasive mechanical ventilation. And here the term prophylactically is very important. It can be used in immunocompromised and post-transplant patients, though presently gradually we are having data that in immunocompromised cancer patients also, it is not a very bad idea to intubate when they are requiring intubation rather than going with NIV, because the early intubation outcomes are also improving in this subgroup of patients. And what are the clinical conditions when you should not use NIV? We should not use it routinely in normo or mildly hypercapnic patient with acute exacerbation of COPD without acidosis. It will cause alkalosis, and which is not desirable. Similarly, if the patient has a chronic CO2 returner, we should not use NIV in them. Just because patient has a PCO2 of 60 or 50 with a pH which is compensated, then it will cause unnecessary alkalosis. We should not use in acute hypoxic respiratory failure, specifically if the PF ratio is less than 150 or that is moderate to severe hypoxia. It will delay intubation, and as a result, because the patient is spontaneously breathing with uncontrolled volume of pressure, it can cause CILI, that is self-inflicting lung injury, and eventually it will compromise the final outcome. In post-surgical patients, we should not use it, and we should not use it as a treatment option for respiratory failure post-extubation. Prophylactically, it's okay, it's a good idea, but if there is impending respiratory failure that has been set in, then we should not use it and should go for intubation. Third is proper initiation of the NIV. We all know that morning shows the day, so once we start it properly in a controlled environment, then probably the outcome will be better. The chance of success will be better. So we have a certain clinical criteria to consider NIV, like moderate to severe respiratory distress, patient is tachypneic, accessory muscles are working, or there is an abdominal paradox. That means the chest wall and abdomen is not moving in the same direction. When chest wall is going anteriorly, abdomen is going in, and vice versa. There may be a blood gas derangement, and there may be a patient is hypoxic. That is mild hypoxia that we have already discussed. So most important to get a successful NIV is counseling and communicating with the patients. We have to give a clear idea to the patient that what he or she can expect with that mask. So we discussed that we'll put a mask, we'll connect with the machine, it will give some positive pressure, it will give some air coming to it, you will feel a pressure. But if you're able to breathe with the machine, then it will help your respiratory problem. You will feel better, you will feel symptomatically better. And at the same time, we explain that if you do not like, maybe after 30 minutes to 1 hour, we'll remove it. It's not like that you have to continue with it unless you are comfortable. And initially, it is a good idea to put the mask lightly or allow the patient to tighten the mask as per his convenience. Now, once the patient is able to synchronously breathe with the machine and he feels comfortable, he understands that it's going to help him, probably we can gradually make it tight to decrease the amount of leak. It is always a balance between the leak and the patient's comfort. Next is proper maintenance. We started NIV, now we have to maintain that NIV, specifically in scenario when we know that patient will need NIV for some duration, maybe few days. So the patient comfort and counseling become very important. We have to keep on discussing with them whether they're comfortable or not, whether they have any problem, and try to sort it if it is solvable. Here, interface can play a very important role. Mostly what we use oronasal. Now, if the patient is on NIV from some duration, there may be some pressure ulcers on the nose or on the chin. So what we can do, can prophylactically put some padding over there, or in certain situation we can change to other modalities or other interfaces like nasal mask, full face mask, or maybe a helmet. Does any one has advantage over other? There is a theoretical possibility of massive difference in internal volume and effective dead space of these masks. Apparently, if you look at those masks, it appears like that. But if you look at the clinical and physiological studies, there is no difference of dynamic dead space on the patient effort, arterial blood gas exchange, and minute ventilation. And as I already mentioned, oronasal masks are most commonly used at as high as 70% of cases. What are the pharmacological interventions? Along with non-pharmacological intervention or counseling, sometimes they are also important. Though the use of sedation is not that common with NIV in ICU. In this 3,500 patients database, they have found only 3.4% cases were sedated, either intermittently with boluses of risperidone and haloperidol, with a continuous infusion of dexmedetomidine, midazolam, or propofol, with titration of the RAS score. In this sedation, uh, probably dexmedetomidine will have a significant edge in the present era. And they have shown that sedation is potentially useful to avoid NIV failure in both do not intubate cases and in not do not intubate, that is routine cases also. Because the patient will feel comfortable, a little sleepy, and that may help him to tolerate this mask better. Another study involving 322 ICUs in 30 countries, they shown that if you use analgesia or sedation, they have used it in up to 20% cases of NIV, and it is safe if you use any one of them. Now, humidification, it is not that commonly used, or we discussed humidification when the patient is an NIV. Options are heat moist exchanger and heated humidifier. An RCT of 15 center with 247 patients has found that there is no significant difference in regards of mucosal dryness, intubation rate, PSCO2, NIV duration, ICU and hospital length of stay, and ICU mortality with these two modalities of humidification. It is not routinely used, specifically when the patient is on bilevel ventilation or portable NIV, because it increases the rate space and the work of breathing. And also, it is really very difficult to put the HME proximal to the expiratory port. Really very challenging. Now, patients who complain of dryness of respiratory tract or thick tenacious secretion, heated humidification, or HME can be considered in that subgroup of patients. The most important aspect of why we are doing so many interventions or adjusting so many things is to get a synchrony between the man and the machine. Now, if the patient is able to breathe synchronously with the machine, so gas delivery, then probably the chances of success rate or of this NIV trial will be highest. Next is monitoring. We put those patients, now you have to monitor certain clinical aspect to check whether we are going towards our expected direction or will be able to achieve what we can expect in these patients. So, but we need to remember there are some predictors of that says there is a high chance of NIV failure, like to begin with. And those are high severity score with illness like Apache 2, SAP or SOFA score, old age, failure to improve after 1 or 2 hours of NIV trial. That means the problem is not immediately reversible. Unlike in acute exertion COPD, that may settle down within 1 or 2 hours. That's why we use in NIV extensively in COPD, but not in asthma, because they take time to settle down. Multi-organ involvement, premorbid status, pH less than 7.25, the chance of failure is higher. Initiation in patient with hypercapnic failure with a pH less than 7.25, Difficult to identify the etiology of respiratory failure. Those things are not going to settle down. And specifically in a hypoxic patients like in ARDS or pneumonia, specifically if the patient has a moderate to severe hypoxia, the PaTFR to less than 150. And at the same time, we need to remember that we have other non-invasive modalities also, like HFNC. And now, if the problem is not ventilation but oxygenation, HFNC can be a very good alternative compared to BiPAP. And this plurally trial, which was done for acute hypoxic respiratory failure patient without hypercarbia, with a PaTFR less than 300, it shows that HFNC is non-inferior to NIV in terms of outcome and better than standard oxygen therapy. But it has also shown that compliance or patient comfort is much higher with HFNC compared to NIV. But there are multiple studies which shown that even for a hypercarbic respiratory failure, if you keep the flow of HFNC low, that is around 30 to 40 liter per minute, it can be used also with close monitoring. And when you combine, there is scope to combine HFNC with NIV in certain aspect. This is the OPTI-NIV trial, which has used these two modalities together for pre-oxygenation and apneic oxygenation during intubation. So they use NIV for pre-oxygenation and HFNC for apneic oxygenation during the procedure with a better hypoxic outcome. And this combination can be used. We have used it in COVID also to prevent intubation, can be used in appropriate clinical scenario. Another important aspect, if your plan A is not working, don't hesitate to shift to plan B and intubate those patients. Don't stretch them too much in NIV if the patient is deteriorating or not improving. NIV failure can be because of multiple reasons. It can be immediate, early, or late. Immediate means it's within 1 hour, early within 48 hours, and late is after 48 hours. Most of the time, the cause of early NIV failure is because of related to the airway. Patient may be hypercapnic encephalopathy and coma, not able to maintain airway. He may be intolerant psychomotor agitation, not tolerating, or weak cough or profuse secretion that is not able to handle, along with the dysynchrony. So there will cause an immediate failure and need for immediate intubation if these problems are not sorted out. Early problems can be because of hypoxic respiratory failure and hypercarbic respiratory failure. Mostly the problem is that the pathology is not getting reversed. So they need to continue with an NIV and eventually they may not able to comply with the requirement. And late failure is mainly because of sleep disturbance. That is, patient is not able to sleep with NIV for a few days and then they become agitated, restless, and the compliance gradually drops. The usage of NIV for a prolonged period is mostly used in immunocompromised patients. And we sometimes have patients we are not supposed to intubate because the patient has a poor prognosis, advanced disease, or severely immunocompromised, and family member does not agree with intubation. In those aspects, we have experience with prolonged NIV in our ICUs. And this what we do, we usually keep on changing the interface from a oronasal maybe to a nasal mask, full face mask, sometimes give to an HFNC if the patient causes hypoxia, then change back and try to go according to the patient's comfort and patient's wish. And the last aspect, if with God's grace we are able to tide over the crisis, patient's primary pathology is reversing or reversed, and we are planning to take off the NIV. That is the winning process. So present we have a patient which is clinically stable, reasonable saturation, respiratory rate, heart rate, blood pressure, and there's no significant sign of respiratory distress. Most important is the clinical parameters and the patient's how the patient is feeling clinically, along with maybe an arterial pH which is more than 7.35. So studies have shown that protocol-based weaning causes significant reduction in the duration of NIV and length of stay in ICU compared to a physician-directed weaning. So when you go by protocol-based weaning, what are the strategies we can adopt? It can be a stepwise reduction in the NIV pressure support, stepwise reduction in the NIV duration, and immediate withdrawal of the NIV after stabilization. So what we mostly do, we usually stepwise reduce the NIV support. Once the patient is on maybe 12/6 or 14/6 or 14/8 pressure support, then we start decreasing the NIV duration. And studies shown that if you remove them immediately, there is an increased chance of weaning failure with immediate removal group. So that was not statistically significant. So to conclude, NIV is an important respiratory support that we are using daily in, day out in our ICUs and HDU areas. So we have extensive user experience and there's a lot of scope to use in ICU. But what we need a protocolized evidence-based approach. When to start NIV, whom to start NIV, and when to stop NIV. And that will help. It will give us a higher chance of NIV success in our clinical patients. And the most important aspect in this is we should know when to stop to prevent poor outcome in those patients and when to shift from NIV to intubation. By this, I conclude my presentation. Thank you.